I just thought, I know it's transverse abdominis is not a big thing, and it's a bit of a tough scan. Just run it through and then I'll pull it through for you so you can see, so I can break it down for you. But gentleman turns up with what he thinks is a lump on his tummy, on the side of his tummy, but I can't feel a lump, but he can see it. And so this is the left side. So you got transversus and internal oblique.
Yes.
Yeah.
Yes.
And then I run the video, and that's his left transversus internal oblique. And do you see what happens when it comes down here?
Yes.
It comes down below the level of the crest, and you get this sort of widening of it there. And that's on the normal left side. On the right side, we come down. Transversus is, if anything, hypertrophied more proximally, and then it disappears. You see that?
Yeah.
Yeah. And look what's happened to internal oblique. So it's suddenly very sort of fatty infiltrated. So healthy muscle. Abnormal, it's got thin, and transversus has disappeared. And then you carry on through down below the level of the crest, and you see it come back up again.
So it seems like a component has retracted, like torn. No, what is it?
No way. That I think you'd have to crash land your aeroplane before you'd ever say transversus. This is the clue. Atrophy. He remembers one episode when I quizzed him, because he couldn't remember. It doesn't have any back pain, but he said he had one episode of severe back pain.
So are you inferring it is neurogenic atrophy from a wow.
Yep. There you go. See that? Just gone away. And the internal oblique is trying to as well. But see, so that's abnormal, back to normal. And so it's just scanning down and just goes normal, 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 not normal, and then normal again. And it must just be one level.
So
spinal level.
Is it innervated by the same type of thing as sensory? I don't mean the same nerve, but does the...
If I remember rightly, it's a branch of the... It's one of those hypoinguinal. You've got the one that goes down the groin, and then the other one that goes branches off. It's those levels, and it must just be a branch of that got picked off, because you go on the other side, and you see that normal going from lower, where you see this sort of V-shaped or wedge-shaped.
When you say lower, you're talking below the iliac crest. Is that what you're saying?
As you go below the iliac crest, transversus goes looking from like this.
Yes.
And then it starts to look like this as it comes off, as the iliac crest changes shape. And, and so it stops arising from the thoracolumbar fascia and starts arising from the crest. Yep.
The bony crest. Okay.
Yeah. So you've got that different shape to it there. And then you go to that bit where it's
the thoracolumbar. Yeah. And show me the other side again.
Here we go. So you lose it, and then you get the crest bit.
John, is that gas down below? What is that?
Yeah, that's the technical term for this is windy pops. Is in my book anyway.
I love it. So first off, your ability to identify that echo signature in the internal oblique is atrophy, because it's a homogeneous, I mean, it's a textured brightness.
Yeah.
And so that tells you that there is atrophy going on, and the total loss of dimension in the transverse abdominis is what tells you that it's no longer viable.
Yeah, well, it is just atrophied, but
atrophied away.
It's got really, really thin, so it's probably this.
Wow. Wow.
You see, if you follow the lines, if you follow the boundary lines, as you come through, you'll see they're still patent there. Yeah.
Yeah.
Yeah. So I just thought a little interesting one.
Yes.
I might retweet it for you.
I think that would be great, because I think it's too heady for 95% of the world, maybe 98%.
I did think it was one of those ones where you need to take people through it, but yeah, but I think it's one of those things that worth seeing. It's worth understanding what's going on there, because for your understanding of the anatomy and of looking at the abdominal wall, if you're going to.
Yes, I just think I think the number of people out there who are claiming to be MSK ultrasound people, they're basically shoulder people, or they're basically ankle or knee type people, and they just avoid any type of core, and so I think you're paring this down to about a half of a brain out there.
So this might be too complicated a picture. This was not an easy scan. But I just thought you might want to have a look at some pictures of bowel close to the skin. This patient had a big hernia, so these are loops of bowel, but they're outside of the tummy wall.
So show me the tummy. That's the tummy wall. That's the fascia that holds the gut in.
That's going to be that's a bit of rectus probably.
Okay.
Not a normal rectus, but that's rectus. This is a patient with a large abdominal hernia, incisional hernia, where they've had major surgery, and the bowel has come out into the subcutaneous fat here. And so you've got fluid and loops of bowel within the abdominal wall. And that's a bit of water going around. You can just see the peristalsis and the fluid. I set that running. See the fluid whooshing round. That's a bit watery.
Yeah.
Going on. And you see there the bright line it will be air, and the slightly less bright appearance is poo. Where you don't get the dark shadow, that will be air. That's the muscle wall, the mucosas, and there's some fluid going around inside the bowels. Probably a bit esoteric for the MSK population.
Yes. But I'll tell you what it does to me, John. It gives me grayscale perspectives, and it takes me back to the physics of what air looks like and what denser material looks like, because there's a hard flip that occurs in the minds of a sonographer when it's air compared to the density of poo, and yet one is bright and the other one is see-through, sort of, based on its moisture content, and then we go to metal, which is again bright. So there's that weird.
Yeah.
All right, talk to me. Is this a long head?
Yep. A very normal one. Very slim patient. I just quite liked this. It was brighter in the actual, when I was actually scanning it. I just liked the way you could see the musculotendinous junction developing.
Yes.
So I just thought that
you're dropping inferior through pec major down to where it's actually becoming the actual biceps muscles. Yeah,
I just saw that and thought, oh, that's quite nice. No, that's 2017-24. Let's go. Let's stay in May. Injection. I've been doing a lot of injections
Good.
recently.
Let me see them. You know, I'm intrigued by them because it's like going to a zoo. I can't do them, so I just like watching them.
Yeah. This is something I always look for in de Quervains now. The where it doesn't where it's denosed. So if we go back here, this is not the best example I've seen. I've had a lot of examples recently where it's where you scan it, but I wasn't really on my best metal there. You see, it's just very sticky there. It doesn't want to go. This is a slice through the tendon, the abductor pollicis, and that's the thickened pulley. Yeah,
that's very nice.
And then you see the thickened pulley somewhere around here. I'm sure, yeah, there on the color shot. There. And then I think there was an injection involved. Not sure how elegantly this was, but yeah, so you just stick a needle in and you inject around it.
The goal here is anti-inflammatory, not necessarily stretching, or is it both?
No, anti-inflammatory. I wouldn't necessarily stretch. I'm not quite sure what stretching would achieve in this environment. I'm not going. It's all it would do is cause damage. I think. I do less, relatively speaking, less of that sort of thing. Let's try 21st incidental. Oh, this is not clinically relevant in this case, but this is the ulnar nerve. Just looks a bit thicker there.
This is at the elbow, right?
Yeah. So it looks normal there. A little bit thickened over there, but it was asymptomatic and it was bilateral. So just slight thickening there. Not always clinically relevant would be my...
Give me a percent. When you say slightly thickened, would you say 50% or would you 25% or 2x?
Well, let's have a look. There's your diameter in short axis where it's normal. Now, I don't know that I got a great shot of it, but if you go there...
Yeah.
It's just... or what we say, it's probably twice the volume.
Yeah, I would say twice 2x. Yeah,
but I'm probably not truly. I'm not right on it. I was not. This is an oddity. They turn up occasionally. It's a teeny weeny little lump on the dorsum of someone's PIP joint.
Really?
Yeah, you get little nodules there, and they're not that. They're pretty uncommon. And I don't think there's no one's got any particularly strong views as to what they are, but they turn up. They're hard to see unless you've got good quality kit. Just this thickening here.
They are not tethered in any way to the extensor mechanism. They're simply, they are.
I think they can be, yes. But there's not much to it. They're called Geralds nodes. And they're just a little bit of soft tissue thickening there and associated with Dupuytren's, but in the literature, but not, but completely random thing. But they turn up and they want to know what it is, and they think it's going to be a ganglion. Someone tells them I think someone had scanned that and said they thought it might be a ganglion, and it's not. It's just a little, if you see them, feels like a little fatty lump over the top of the PIP joints.
Now, you're saying it's not a ganglion because, by definition, the ganglion needs to have a root to the actual joint?
It has to be fluid-filled, and that's isn't fluid. It has to be a cyst. That's just a dark splodge, and it's a dark bit of soft tissue.
You know that because your eyes are registering a ever so slight grayscale in... Oh, I see. Yeah, I got it. All right. Yeah.
So just soft tissue.
Yeah.
I think someone had scanned it and said, I think they had some sort of radiological thing when they said they thought it was a little ganglion, but
should
not.
There have been a ganglion there, would you have injected it, or would you have verified? Okay, that's what would have been your MO on that?
Depends how keen the patient was to do something about it and how big it was. But you know, if I'm convinced it's a ganglion, then I'll stick a needle in it if the patient wants me to, because it's less invasive than the alternatives.
Yeah.
So let's have a look. Another May. Let's see, tennis elbow. Always, we always like a bit of tennis elbow action.
Yeah. Your buddy Bird from Australia has had my eyes go a little bit more, I guess we would have to say, medial than where I was previously scanning, to look more for the ECRB as a component of that, rather than trying to find the common extensor tendon or the whatever.
So this is me coming out here. There, go back to that bit, because that's me looking at the ERCB component. We go. It's quite subtle. There. You see this? I've only got a few slides. See the V shape there?
Yes.
This muscle, when you come out, the anterior, you come out in short axis along the thing, as it becomes muscle here, you'll see this bit anteriorly with the V pointing towards the common extensor origin, and that is the muscular tendinous junction of the ERCB. And it has this. It actually goes all the way up to there, like a. Was it the old lambda in Greek?
Oh, that's right. Yes, that's right.
That fold there.
Yeah.
But what you see distinctly is this V, and it's not shown well here. But this muscle belly, has two parts, but the division between them is very subtle, and is only a slight difference in texture often. And this is the RCB brevis, and this is the longus here. But these fibers, you'll see if you watch the direction, these fibers all go and join this fine line here that starts flatter and then folds. Like, imagine if you had a magazine. You're holding a magazine open, and then as you close, if you closed it, imagine closing it and it coming together at the bottom. You know, but leaving the not closing it completely, so holding it in your hands.
Yes.
So or a soft child's book cover.
That would be how you, when you come more distal, that happens toward the actual origin.
As you go more proximal towards the origin, yes. So
proximal.
So I've only got a very short clip of it there, but you can see it just flattening.
Yes.
Like you're closing the book or the flower.
Now you bring that up because is that intramuscular fascia a source of irritability, or is it just to help anatomy or to identify?
It's just to help your anatomy, because you follow those fibers in, and that gives you the direction. So when you scan this bit of, this is the injured part of the common extensor origin. Typically, that's normally where the pathology is. Not always, but normally where it is. And if you're following that in, then if you scan that bit, if you find this bit and you scan it, long section and short section, then you get good pictures of the pathology. And what Steve Bird doesn't quite do is, as he's in his videos, he keeps the probe in the same plane. And so he loses, as he scans it on his images, you lose sight of the radial head. But I try to come around as I do it. And so so you should be able to keep the bone nicely in view when you get into your long section. And, you know, it's just a difference in style.
Right.
That's there. So this doesn't quite look as good as you would normally do, because you are just following those fibers rather than the main body of it. But you still get the bone, and you see the abnormal portion of the thing. And you get that linearity of the fibers, because they are coming in like this. And these ones are the ones you're looking at that are in this sort of folding book appearance, and then it masses up and swells up. And it's those fibers that you will, if you can scan that, your scanner's probably going to struggle to get the detail. It's not got the frequency range to see these well, or the spatial, it hasn't quite got the spatial resolution for that. But that's where I come back. So yeah, so that's the more normal part of it. And then I go further back and you see it's all swelling. So you see the difference there. That's the body where you traditionally look in.
Yes.
In the midpoint of it. And then as you come back through, that's the wrong way, and you go that way.
Yeah, see, I've got to do that more. Both of you guys have turned me on to that, because I think I've been missing a lot of real pathology by not finding the ECRB. Yeah,
it's just a nice shortcut, because it's
do I understand this is a subacromial? I mean, this is oh, so you're just simply going into the subacromial bursa.
Yeah.
But you're going over the supraspinatus.
Yes, in short axis. Yeah. This is a little bit of patellar tendinosis. This is in a quite a severe OA, if I remember rightly. So it's not clinically so relevant, but certainly in my practice, I don't do a lot of sports medicine, so I don't get to see a lot of patellar tendinosis. So I'm always pleased to see it when I see it. Like proper MSK ultrasound.
Proper.
Lots of, this was I've seen some real variety in the presentations of OA of the shoulder recently, and I probably have another one if I can find it for you. But can you see there how much the joint space has gone in this?
Yeah, this is posterior window looking at the humeral head on the glenoid.
Yeah, and they're just, often this can be untidy with OA, but this is a genuine bone on bone classic. And I have another case, if we get round to it, I'll show you, where you actually see the loss of cartilage on the humeral head.
I'd like to see that. And is that darker area capsular fluid on the posterior window one, or the one? Yeah, right there. Is that capsular fluid there?
Probably, yes.
And just debris from the labrum, or well degenerated labrum, those little white things that are around that?
I would guess so. Yeah. It could be just about anything under the circumstances. I don't know where. 24th OA cartilage. Yeah. Right. So let's have a look. So yes, look at this humeral head. Let's have a look. See the cartilage going?
Yes.
Sort of thing you could so easily walk past and not notice.
And do you figure this is the wear pattern from where it actually is making contact with the glenoid?
Yep, I think this is just like on cartilage loss.
Yeah.
More typical.
Yeah.
And I've not really seen it there without a huge amount. And I can't remember quite what the story was, but it was just a little bit unusual OA. It wasn't a classic OA. This is cartilage damage for whatever reason. So presumably an atypical mechanism. Where were we? We were some 19th, yeah. Patellar OA shoulder joint space. This will be way too obscure. I'm not sure I can see what's going on here, but so you have to take my word for it. But this is the origin of the long-headed biceps on the glenoid.
Wow. How are you getting that? Are you coming up?
It was just a very messy shoulder, and there was just a good access.
Wow! So that's that little what do they call that? The little where it inserts onto the top of a 12 o'clock position of the glenoid. That little Glenoid tubercle there or something.
Yeah, you don't often see it. No, I certainly didn't get a good view of it, but it was just, wow, I don't normally get to see that. I think there was a lot of, the biceps was spared, and I think there was a massive tear, and so everything had pushed up and out of the way, and the humeral head had come, and you just said, oh well, I'll take it when I get it. Oh, that's just a random piece of calcification in subscapularis, but it's denting the thing, so it could be symptomatic. In actual fact, I think this patient had a lot of calcification elsewhere. In fact, this is probably the back of the same shoulder. Yeah.
My eyes see this, what you're just showing me now, as like an infiltration of fibrous material by a calcinosis, whereas that other one almost seemed like it was an ectopic piece of chondral tissue, or a piece of calcification, like, I don't know, debris, big piece of debris.
Yeah, and that's probably what's going on in that what's what they would call the middle section of the thing, whereas the other area, it is probably further on in its evolution.
Yes. And
starting to disperse or soften or whatever.
Does it all, in your mind, just basically say, oh, there's another one?
Yeah. This
is just evidence that we're getting old and eating too much something, or is this?
I see it. I see it in such a cross section of the population that it's. I presume there's some sort of genetic element, perhaps.
Yeah.
Or
so, do you think that if there is an inflammatory event associated at the same time with that, does it, on the evolution of that inflammation, did that debris and that granular type restriction create friction and disrupt movement, and so it brought in the prostaglandins, etc., or was there inflammation and the calcium came in to dilute all that toxins? Or do you even care? Because I don't.
I care right up to the point when I'm waiting to get some useful information to have to form that opinion on. Okay. But at the moment, I haven't got it. I just don't know, and I'm not, and I don't have a strong enough opinion on what it might be to bullshit about it.
Is this long head, or what is this? I'm not even knowing where we're oriented.
Go on then. Try and have a guess then.
I'm seeing what looks like it's the glenoid on the left.
You're on the wrong continent.
Wait, just a second. Oh, we're 4 centimeters down.
No, so, you're not in the wrong. You're in the wrong state. You're on the wrong continent. This is South America.
This can't be hip then.
No, this is a PCL.
Oh my goodness!
That's a little cyst wrapping around it.
John, I want to have you help me know where the probe is. As are we posterior here, or we have to be behind?
Yeah.
And so it's the humeral. I mean, it's the femoral condyles that are coming in on the bottom left.
No, this is all. You're not seeing the condyle at all, I think, in that. Oh,
yes, that right there.
There, yeah, that's the femoral condyle. There.
Okay.
So I scan this routinely when I scan a knee.
I need to know how to do that.
You know how to scan the medial joint line, yeah?
Yes.
So you scan the medial joint line. Most people stop when they get to when they run up against the hamstring.
Yeah, the posterior horn. I mean, as best you can.
But what I do is I roll the patient onto their front.
Yes.
I get them to relax their leg, and if they're and sometimes I hook my arm under their shin.
tibia, yeah.
To make it soft. Or if they can leave it straight, but sometimes it makes it deeper. And then I carry on scanning the tibial plateau, and you ignore the condyle because that's not your orientation. You see it, but you scan relative to the tibial plateau, and you should be able to scan the tibial plateau just about all the way around. As you go around the back, it's nice and fat, and you can, and what you'll find is that if you lift the knee slightly, lift the foot slightly, but with the hamstring staying relaxed, you'll then find that the triangle of cartilage moves posteriorly, and you can often see that quite well. Not necessarily to be able to diagnose it, but it makes a nice picture. But anyway, the tibial plateau stays as this nice level cut off like this. So you follow it around like that, and then suddenly it does that. And
when it suddenly does that, that's one of the places for the PCL.
That ski slope.
Yes.
Is the insertion of the PCL. Is where the PCL inserts.
Would you say that if I practiced that, I would be able to see that reasonably resolved in 75%, or would you say 90%?
Well, sometimes they look very different in different people, but pretty much anyone who's relatively straightforward to scan at that depth, you will see it, and some of them will look more worn, but it's quite easy to get to because you get that. That's the back of the tibial plateau. Yeah. And then it goes from there, and it just goes like that and back up again.
And in essence, when they're on their tummy, you're cradling their shin, basically both to assess the level of tone that they have in their hamstrings and to take some of the tension off just
to make it softer behind the knee.
And then you bring yourself around from the medial joint line, and you go over hamstring, and you keep the edge of the tibia in view until it all of a sudden takes the angle like this, and the fibers that are coming out are your cruciates.
Yeah, are your posterior cruciate.
My wife's going to have some goo on the back of her knee tonight, John.
Yeah. What you do is you see it go up and then disappear, and that's normal. Because it's going up and it's winding around the ACL probably, and so you don't see a tendon going all the way through. You can, on a nice example, on a very young person with good thing, you can actually catch it in short axis and follow it up in short axis, and then you sometimes can actually see a shadow of it attaching onto the inside of the condyle. I can't even remember which way it goes now.
Wow.
But yeah, so that's not a diagnostic test. That's just a fun thing to do.
Yeah, well, it would be nice to be able to see it, because I would imagine that if there was, we're in the region of where if there was an acute injury, we would certainly expect complex fluid, or we would certainly expect some level of effusion. But this looks like it's more of a reactive cyst. You were saying, yes?
This is long-standing, and there's a cyst that wraps around it, which may relate to a previous injury, but you're just guessing. It was actually reported on the MR, and I went looking for it specifically just because it's there. This was severe late-stage calcific tendinosis. So this is where it's all come out, and it's liquefied. It's actually liquefied there. You can see this is the subacromial bursa, and this is quite marked inflammation. This is marked synovitis there. This is calcinosis here, and soft calcinosis here. This is the late stage.
I'm looking at one of the facets on the greater tuberosity okay.
Yeah, so that's the biceps there. Not a great picture of the biceps. I'm actually imaging the bursa, and this sort of almost tophus-like calcification there, and sort of blistering calcific tendinosis.
What did you do on this, John?
Stuck a needle in it.
And did the lavage type thing, or
yeah. So that was that, and. So seeing this the more I look for this, the more I see it in the OA wrists that come my way. This widening of the
scapholunate.
Scapholunate. That's an abnormal looking scaphoid, and then if we come back, drag that back, and that's quite a wide looking, mobile scapholunate joint. So
the extensor digitorum above that, and there's quite a bit of fluid around that area too.
Yeah, but no discernible ligament. So a little bit of instability there. Frozen shoulder.
Yeah, I want to see this. I've tried to figure. I thought I found some of these. Not. But they weren't that huge and that thick.
No, they are very inconsistent, even in people with frozen shoulder. I saw someone's frozen shoulder where they're on the normal side, it looked better than on the abnormal side, it looked better than the normal side.
Oh, really? But what do? You do the rotation to see if it tethers, or is it just more of an incidental, wow, that looks thick?
Yeah, you look at it, looks thick. You say they've got a restriction in external rotation, and does it tighten up like a piece of rope at the stopping point? And that all sort of suggests to me that, you know, this is pretty much frozen shoulder. So it's these are the things that we do. Yeah, so this is rheumatoid, and this is unusual in that this patient was booked for a scan and then saw the rheumatology department, and they made the diagnosis. So this was confirmed synovitis, rheumatoid synovitis here.
Because your eyes are looking at the pock marks or the faults in the periosteum below. No,
this is the periosteum is fine. If it looks wrong, it's my bad scanning. What I'm looking for is the curvature on that synovitis.
Okay.
No, it's not following. If you have got anything there, it should follow the contour of the capitate. Whereas this balloons up, it's sort of, that has a swollen look.
Okay. Man, I'm not good at recognizing that topography to know my landmarks down in that wrist.
Yeah, but that's one of my favorite landmarks because it's so distinctive. The bell shape of the
like a peanut or like a yeah. Interesting.
And but yeah, lots of synovitis in the synovial sheath and in the mid-carpal synovium recess. Isolated. This is another de Quervains. I see a lot of de Quervains recently. This is isolated to extensor pollicis brevis. You see there it blocking.
Wow, sure enough.
Getting stuck. Again, that thick picture there. But that was another one of these cases where it's the extensor brevis only that was markedly thickened. That's dislocated biceps. That's always a good one. These can be tricky, I think.
Yes, they can.
Yeah. See how it's drifting away from the greater tuberosity.
Wow. Wow.
So there's the tuberosity there, and he's gone that way.
Wow.
And he's there lying on top of the.
That's
the
fabulous.
head. So probably a upper fibers of subscap tear as well. So he's coming over the low, the classic lower fibers of subscapularis that are more meat, less tendon.
Yes.
When you get past there, you don't really see very much tendon. It's straight up that biceps. If you follow it, it's straight onto the bone. which is shouting out at you that the subscap is torn.
The bone is, or the dimension is, or the fact that you don't see.
You've got subscap, long-headed biceps here.
Yes.
You're always going to be suspicious because it's dislocated. Yeah. But as you go back, as you go through there, you know how you get meaty fibers.
Yes.
The lower part of subscap is neat right up until the
right.
thing. But as you go higher up, you should have tendons there. So if this biceps is dislocated, you should see those tendons running either over the top of it or underneath it.
I want to clarify something with you, John. When you say deeper, are you saying profound deeper, or are you saying inferior deeper?
No, just deeper, as in the picture.
So that when we're taking a look at them, so my mind sees the classic cross-sectional insertion point of the subscapularis showing us that interdigitations of dark and white. What I think you're telling me, though, is that, in fact, the more surface layer is going to be more whiter because it's more fibrous, or are you saying the closer to the insertion point, it's more... so let me listen to you.
Okay, so subscapularis?
Yes.
Into like 4 or 5 digits of tendon. And so you've got muscle, tendon, insertion.
Yes.
Except lower down, where it's more like muscle straight into bone. The lower part of it, the most lower fibers, is more muscle, a little bit less tendon.
I will have to make, I've never heard it clearly stated like that, and so I'll just have to visit a little bit south of where I normally scan and take a look at darkening when I'm down there.